Level up your AI skills with the RSNA Imaging AI Certificate Program. Our case based courses are designed to help you gain confidence, improve efficiency, and advance your career in this rapidly evolving field. Due to popular demand, we're extending our special RSNA member only offer of 25% off enrollment for any AI certificate course with promo code MEMBERAI25. Learn more at rsna.org/AI-certificate. This special offer ends November 29th, so act now.
Hi, everyone, and welcome to the RSNA Radiographics podcast. I'm Bahar Mansoori, Associate Professor in the Abdominal Imaging section of the Department of Radiology at the University of Washington. I'm glad you're tuning in today. I'm one of the co-authors on a recently published paper, Musculoskeletal Complications Associated with Radiation Therapy and Immunotherapy. As oncologic therapies grow more sophisticated and extend survival, radiologists increasingly face a complex spectrum of treatment-related musculoskeletal findings. Radiation therapy and immune checkpoint inhibitors, central to modern cancer care, can lead to complications such as fractures, osteoradionecrosis, arthritis, and myositis. Many of these mimic metastatic disease or infection. Today, I will walk you through the key imaging patterns, diagnostic challenges, and clinical implications that every radiologist should know. We will focus on four major areas: radiation-induced injury, immune-related complications, diagnostic pitfalls, and imaging strategies. Let's begin with radiation therapy in Section 1. Radiation therapy remains a cornerstone of cancer treatment, but musculoskeletal effects are often underappreciated. These complications can be acute, subacute, or delayed, sometimes emerging years after treatment. Common manifestations include bone fragility and insufficiency fractures, osteoradionecrosis, cartilage degeneration and joint space narrowing, soft tissue fibrosis and myopathy, and radiation-induced tendinopathy. Let's talk about each of these. Bone fragility and insufficiency fractures, often seen in weight-bearing bones such as the sacrum or pelvis. These fractures may be bilateral and symmetric and can present with marrow edema and subtle cortical disruption. Osteoradionecrosis most frequently affects the mandible, pelvis, or spine. Imaging may show cortical destruction, sclerosis, and gas within the bone. It is crucial to differentiate this from osteomyelitis or tumor recurrence. Cartilage degeneration and joint space narrowing, particularly in irradiated joints leading to secondary osteoarthritis. Soft tissue fibrosis and myopathy. These present as decreased muscle bulk, fatty infiltration, and restricted motion. MRI may show low T1 and T2 signal intensity in affected muscles. Radiation-induced tendinopathy, often subtle but can cause pain and functional limitation. The imaging appearance depends heavily on dose, fractionation, and delivery technique. For example, conventional radiation therapy tends to cause diffuse changes across the radiation field. SBRT produces sharply demarcated zones of injury, often with geographic marrow signal changes. Proton beam therapy, with its Bragg peak precision, can spare adjacent tissues but still cause focal bone damage. A key diagnostic challenge is distinguishing these findings from metastatic disease. For instance, insufficiency fractures may show marrow edema and mimic osseous metastases on MRI or PET-CT. Recognizing the radiation field boundaries and correlating with treatment history is essential. Now in Section 2, let's turn into immunotherapy, specifically immune checkpoint inhibitors. These agents have revolutionized cancer care, but they also introduce a new class of side effects: Immune-related adverse events. In the musculoskeletal system, immune-related adverse events can present as inflammatory arthritis, myositis, enthesitis, polymyalgia-like syndromes, and seronegative spondyloarthropathies. Let's talk about these. Inflammatory arthritis, often symmetric and involving small joints, resembling rheumatoid arthritis but typically seronegative. Myositis presents with muscle pain, weakness, and elevated creatine kinase. MRI shows muscle edema and enhancement. Enthesitis. Inflammation at tendon or ligament insertions, seen as increased signal and enhancement on MRI. Polymyalgia-like syndromes, characterized by proximal muscle stiffness and pain, often without significant imaging findings. Seronegative spondyloarthropathies, including sacroiliitis and axial involvement, which may mimic degenerative or infectious changes. These immune-related adverse events are often seronegative, meaning traditional markers such as rheumatoid factor or anti-CCP are absent. Imaging becomes the cornerstone of diagnosis. MRI is particularly useful for detecting synovial thickening, joint effusions, and muscle inflammation. PET-CT may show increased uptake in inflamed tissues, but distinguishing inflammation from malignancy remains a challenge. Timing is critical. These complications can arise weeks to months after therapy initiation and may persist or evolve even after discontinuation. Awareness of the patient's immunotherapy regimen and its timeline is essential for accurate interpretation. Now let's move on to Section 3, Diagnostic Pitfalls and Mimics. One of the most challenging aspects of post-therapy imaging is differentiating treatment effects from disease progression. Let's walk through a few common mimics. Insufficiency fractures versus metastases. Both may show marrow edema and cortical disruption. Clues favoring fracture include the linear cortical break, location corresponding to a prior radiation field, the lack of an aggressive periosteal reaction, the absence of soft tissue component, and stability or regression at follow-up imaging. Osteoradionecrosis versus osteomyelitis. Both entities can show cortical destruction and soft tissue swelling. Osteoradionecrosis typically occurs within the radiation field and lacks systemic signs of infection. Myositis versus metastatic infiltration. Muscle edema can be seen in both clinical contexts, serologic markers, and sometimes biopsy are needed to differentiate. Immune-related arthritis versus osteoarthritis. Immune-related adverse events arthritis tends to be symmetric and involve atypical joints, whereas osteoarthritis is usually asymmetric and localized. These mimics can lead to misdiagnosis, unnecessary biopsies, or inappropriate treatment. Radiologists must integrate clinical history, treatment timeline, and imaging features to make accurate calls. Collaboration with referring clinicians is key, especially when findings are ambiguous. Now let's move on to the Section 4 and discuss imaging strategies and multidisciplinary collaboration. So, how can we improve diagnostic accuracy and patient care? Know the treatment history. Always review the type of radiation therapy or immunotherapy, timing, and dosage. This context is essential for interpreting imaging findings. Recognize typical pattern. SBRT causes sharply defined marrow changes. ICIs may lead to symmetric joint inflammation or diffuse muscle edema. Choose the right modality. MRI is excellent for soft tissue and marrow evaluations. PET-CT helps assess metabolic activity, but beware of false positives in inflammatory conditions. CT is useful for detecting cortical bone changes and soft tissue calcifications. Communicate with the clinical team. Radiologists play a central role in guiding management. When findings are equivocal, suggest follow-up imaging or biopsy. Raise suspicions for immune-related adverse events or radiation injury when appropriate. Multidisciplinary collaboration is essential. Radiologists should be proactive in tumor boards, radiology consults, and treatment planning discussions. Our insights can directly impact patient outcomes. In summary, musculoskeletal complications of radiation and immunotherapy are diverse, often subtle, and diagnostically challenging. They reflect the complexity of modern cancer care and demand a nuanced radiologic perspective. Today, we explored the imaging manifestations of radiation induced injury and immune related adverse events, walked through common diagnostic pitfalls, and discussed the strategies for improving accuracy and collaboration. Thanks for joining me on Radiographics on Air. I hope the episode offered meaningful insights and had a positive impact on your clinical practice. If you enjoyed this episode, don't forget to rate, review, and subscribe to the RCNA Radiographics podcast. And of course, make sure to visit the Radiographics website to read this article and explore other great publications.